Venous reflux is a severe biomechanical failure. When leg valves buckle and fail, blood flows backward, pooling to create venous hypertension. Seeing this massive retrograde flow on an ultrasound might push you toward surgery, but treating based solely on a glowing screen is a mistake. The 2024 New England Journal of Medicine review makes a critical distinction for the modern standard of care. The sole objective of treatment is to alleviate human discomfort, not to rectify anomalies caught on a scan. Intervention is specifically warranted for patients showing axial reflux in the great or small saphenous veins, who are actively feeling the physical effects of that failure. The benchmark guidelines map appropriate surgical candidates to the CEAP classification system, specifically stages C2S through C6. The deciding factor glows right in the middle, the lowercase s. That denotes symptomatic disease, aching, heaviness, tightness, and cramps. If the structural failures seen on ultrasound do not mathematically correlate with the patient's lived suffering, we do not operate. The calculus changes entirely at advanced stages of disease, specifically CEAP, C5, and C6. Venous leg ulcers are a biological distress signal demanding immediate surgical intervention. This timeline graph from the EVLA trial details exactly why we move fast. Early endovenous ablation cuts the median time to ulcer healing down from 82 days to just 56 days, proving to be both clinically superior and highly cost-effective. Once treatment begins, learners often fall into a trap, using the CEAP class to track a patient's recovery. CEAP is purely a static, descriptive label of the limb's worst feature. It cannot measure clinical progression over time. To accurately track biological change, we use dynamic evaluative instruments. The Venous Clinical Severity Score, or VCSS, combined with patient quality of life surveys like CIVIC, are designed to measure real-time treatment response. CIAP categorizes where the patient starts the race. VCSS is the metric that proves whether your treatment actually worked. The most complex decisions happen in the messy middle of venous disease, where the great saphenous vein, the small saphenous vein, and the connecting perforating veins are all collapsing at the same time. The SVS guidelines establish a strict first rule: ablate the saphenous trunks first, leaving perforating veins untouched. Fixing the main trunk alone drops network pressure. Without a single incision near the perforators, 80% will stabilize once axial reflux is abolished. This split-screen bar chart illustrates the second rule. Treating the tributaries concomitantly is vastly superior to staging the procedures. Isolated ablation leads to a 20.7. Doing it all at once drops that rate to 0. Let's test this logic. A patient presents with massive, glaring reflux on a duplex ultrasound, but they feel absolutely no pain, a CEAP C2A classification. Do you ablate? No. Even with irrefutable duplex evidence, appropriateness criteria dictate that we stay our hand for asymptomatic patients. Mastering surgical sequencing means prioritizing the largest structural failures first and letting the body's natural hemodynamics correct the secondary downstream issues. There are advanced edge cases, in stages C4B to C6, where severe tissue breakdown has set in. The strict rules against treating perforators early may need to flex, even though current trial data remains limited. And when conservative therapies fail, the 2025 SCAI guidelines emphasize that shared decision-making and patient values must drive the final intervention plan. Let's build the evidence-based sequence. Step 1. Truncal veins first, addressing the great or small saphenous veins. Step 2. Handle tributaries concurrently to lower reintervention rates. Step 3. Stop, wait, and reassess. Step 4. Address perforators as a last resort, only if symptoms stubbornly persist. Surgical mastery in venous disease requires discipline. It isn't achieved by hunting shadows on an ultrasound, but by applying an evidence-based sequence that prioritizes the patient's actual lived experience at every step.